This isn't a presentation. You're not going to be called on the carpet to deliver a talk or anything. It is a conversation. And we hope that it's a conversation that you will have with each other. Those of you who have been recipients of 15K Challenge, and those of you who may be considering applying for a 15K Challenge award, there's a lot to learn from those who have gone through the process, I think. So I think I'm going to just throw out one question to kind of get us started here. So those who have had an award, what was the biggest challenge? Not getting the money, but what was the biggest challenge once you had the money? So this is like going to be what I do now.
Well, hi everyone. I'm Abe from Western University in London, and I was privileged to have an award this cycle. I think. So our project was an evaluation of a program called Homes for Women, which was a support service for chronically homeless women, moving them into permanent housing with supports. The vast majority of the women had intake into the program through our local jail. And so there are women who otherwise would have been discharged to homelessness from jail. And so we followed those women. We had qualitative interviews and some quantitative data as well. And also looked at kind of a broader question of asking our community about women's homelessness and services for women who are homeless. And where we are in London, it feels like it's 1950 because we still have to tell people that gender matters when delivering services around homelessness. And so actually through our dialogue, we were able to both kind of be evaluators pulling data, but we were asking questions in critical ways that I think spurred some conversation. Anyway, I could talk about the project forever. It was really fun. For me, it was the one-year timeline. So you have to be very realistic when you're applying for that. You know, a lot of our other grants that we get are 2-year timelines, 3-year timelines, or timelines where maybe it's a year of funding, but then you have, you know, infinitely long time to complete reports and all of that. So it is a very compressed time frame. And so I found it worked best in this project because the project was basically already in process. So we had already engaged, we were engaged as the evaluators already. We had already begun the ethics approval process. And so by the time we heard that we were successful with the funding, we were really able to hit the ground running and get through the project in that 1-year timeline. Otherwise, you know, if we had just tried to start a project from scratch, I think we would have not been able to complete. So yeah, I would say it's a tight timeline. And so what helped and would help you is to look for projects that are, you know, at already some degree of process or development is already well underway.
Okay, great, thank you, Abe. Does anyone else want to speak to that? So we're talking about challenges once you got the challenged money.
Yeah, hi, my name is Sandra, and I worked along with Shirley here on a project called Battered and Brain Injured, supporting and identifying and supporting traumatic brain injury among women survivors of intimate partner violence. And unlike Abe, we started a little more at the beginning of the project, and I would just agree that the timeline was a pretty significant aspect because we had to get our ethics. And then by the time we got ethics, it was the middle of summer. And then we had to recruit people. And recruiting people over the summer can be very challenging. And then we had committed to hold a workshop in September. So we had to get the data and analyze it and put a presentation together for September. So it was very very challenging to get the data and to get participants after a late ethics. So I would agree that either starting earlier or starting a project that's already got its foundations and getting ethics and collecting data as early as possible would be a really good, or have a smaller scale project that you don't need as many people. So.
Before I go to the next person, I just want to remind those who are interested in being interviewed, we're hoping that really short interviews about your projects are going to help us spread the word about what it is that you've done. And those interviews are taking place just down the hallway, around the corner down the hallway in 2513. Okay.
I don't like using these. So, hi, I'm Lynne, and this is Cynthia. We're two public health nurses from Wellington, Dufferin, Guelph Public Health. And I just wanted to add another dimension to the two speakers already. So we had started looking at preconception health in 2013 as part of our nursing assignment for the Ontario Public Health Standards, et cetera, et cetera. So by the time we found out about the potential for the funding, we had done a Let's Search and created a research question, and we're kind of ready to do some of the data acquisition and then the knowledge translation. So yes, the timelines were tight. We had, we ran into things we couldn't avoid. So we did our initial one was with 7 primary care sites across Wellington, Dufferin, Guelph. And then we had a second original plan to take some university information from the University of Guelph and then ran into their ethics application process, which is, we couldn't, the two timelines didn't mesh at all. We're still in that. So we ended up going ahead using the 7 sites. And what I was going to add on behalf of Cynthia and myself is that Women's Exchange was like completely willing to look at the different challenges that we face and worked around them in terms of timelines, so that the report that we have submitted has preliminary findings only, but like stuff that was totally out of our control. It doesn't negate the fact that we're using our money for knowledge translation in 2017, and we've done 3 or 4 projects already. But I just wanted to add that nice part that you're very receptive, and I wouldn't not apply for it based on the fact that the timelines are tight, because there's always a way around everything.
So certainly we recognize that ethics has created a lot of challenges and slowed some projects down, and we do try to take that into consideration within that 1-year expectation.
Okay, thank you. I just want to go and do the other interview. So first, I would like to thank you for the grant that you gave us. But I would like to challenge my colleagues who've just spoken. Some of us have not been in a position to have something going before the grant comes, because we are small organizations struggling, marginalized, as you can see. We are not a university that will have projects already in place, ethics processes already in place. So it's a bit of a challenge, but we worked with it. The biggest challenge we had is what we are tackling today: stigma. Stigma coming from service providers and community leaders. The women, my project was on, our project was on female genital mutilation among African women, and everybody is afraid to talk about it except the women. So we are actually the ones who are stigmatizing some of these issues. The women are ready to go and stand on Capitol Hill and announce to the world what they went through. They want it stopped, but service providers and community leaders are holding back. They're the ones delaying some of the progress around that issue. But we are very happy that we didn't go out looking for women with FGM. We were surprised that it was hard to find any woman without FGM. So we are very grateful to all your support, and we hope that you can give us further funding to do what the women suggested would like to see being done. Thank you.
Well, not just a challenge there, a challenge to us as well. Okay. So we've heard a little bit that time has been challenging, that getting ethics has been a challenge. I just want to remind community organizations that aren't affiliated with the Research Ethics Board that we do have a community-based Research Ethics Board that we refer you to, should that not be something that you have in your own organization. And not just that, we actually cover the cost of having that ethics review completed so that we can really help you in the community do the work that we are funding you to complete. So this last point was, I guess, a challenge not specifically about recruitment, but a little bit about the interface between individuals and systems. Has anyone else had any challenges in getting their project moving because of system-based issues?
Hi, sorry. My name is Dr. Terry Chang, and this is one of the member of on the research team, Peggy Ying. And our project was looking at developing a culturally tailored online self-help program for Chinese women living with breast cancer. And I don't know if this was a systemic issue. I work at Princess Margaret. It's a very large organization. The barrier actually that came up was didn't know where the check went to. Apparently, the check was sent out on time, but it sat somewhere in big organization, lost in space for 4 months. So I guess, and it wasn't until I start, contacting a Women Exchange, find out, okay, where's the money? It's 4 months now, and then we did a search, like a detectives, and found out there's a check sitting there, and didn't know who I was, didn't know where the check to assign to. So I wasn't sure systemically how these checks are issued. I guess work in a large corporation, organization, they just go to our research finance department. So that's kind of was the barrier that I encountered. Is they lost my money.
Makes it hard to meet that 1-year timeline if you're waiting 4 months.
And interesting at a large organization as well.
I wonder whether you wanted to speak to any of some of the challenges that you were facing at the sort of structural or institutional level. And
I guess what we had learned was, we had, as a public health unit, we had different commitments to meet, and then we had to go through each of the levels of the organization. So when we looked at the research, it came out with 2 themes: healthcare provider outreach and an innovative strategy for the delivery of preconception healthcare. So we started off with a community survey, and everyone said, like, what is preconception healthcare? We did the public health units across Ontario and got 26 out of the 36. And then we did our own managers just to do individual surveys. And then when it came to looking at a site, we thought, well, primary care would fit really well. And then we had to go through our own organization because there was already a committee in place to access primary care, and we couldn't sort of just jump ahead and say, well, we have this really neat project. We had to follow the rules and the yellow brick road sort of thing. And then we developed a product, and then ended up having to put it on hold, the video piece of it at the end, because we I don't want to say it if anybody's in the room that's related to. We ran into barriers. Is that what? Fair enough. Or barriers from the organizational level that we had tried to be innovative, and we had moved ahead thinking that we were crossing our T's and dotting our I's, and then when the initial video was made and we went to show it, it was kibosh is not a technical term, but it was stopped, and it needs to be re-edited, so we didn't make the timeline. So is that what you meant in terms of,
so there are challenges with large organizations, challenges with small organizations. The challenges are a little bit different. I just wanted to speak to the check issue, because Maeve just said that I should indicate that the checks go out with your name actually down on the bottom of the check. And what I always do, and I work in a much smaller organization, is I let our finance department know when I'm expecting a check in.
Yeah, so I want to pick up on a bit of what I said earlier about engaging our community, about tough conversations about services for women. Because one of the issues we encountered was that doing research with community service providers and the trust around kind of confidentiality. And so we had some tough questions to ask them about how services are currently being provided for women, how they're working for women. And you could tell them again and again, we are going to anonymize this data, and you start getting those canned answers, right? And so I was talking to a shelter provider, and it provides services for men and women and youth and everyone. And I knew women were having very bad experiences in that shelter, and so they were saying, we have great outcomes, we serve everyone equally, and so I said, you can be honest, and they weren't being honest, and so I said, okay, so let me ask you this, you track stats on incidents in your shelter, yes. Do you track stats on incidents of sexual assault? Yes. So what's the gender breakdown on who's being sexually assaulted in your shelter? And they said, okay, you're right. Women are not having the same experiences as men. And so just breaking through, helping community providers understand the difference between research and an interview with the local newspaper, which is maybe who they're more used to talking to, and just helping them be honest about that, I think, is a real adventure of doing this kind of work, where we are, a lot of us, touching on some very difficult subjects, and subjects where community providers do all kinds of amazing work, but perhaps we're interested in an area because there is a gap, and that's hard for communities to identify gaps around FGM or around refugees or whatever the issue is.
Okay, we have a comment over there, Paula, here too. Okay.
Do I have the time? Yes, you do. I think our problem is, our challenge is a little bit different from the majority of the cases we've heard so far. Our project is Heal and Connect for the health and well-being of Oromo women and girls. And we are Oromo women from Ethiopia who came as refugees to Canada. And I'm here with 3 research assistants who've been working with me and with other community elders who have not been able to make it today. But our challenge is, yes, it's the challenge of big ambition. It's a very ambitious project that we kind of designed. And we did run into that check issue. The check was sitting somewhere like for 2 months, not 4, for 2 months, and there was that issue. But there was also the ambition. The project was so ambitious, we couldn't get it. And so there's the timeline issue, which was granted. We were granted extension, thankfully. We were really, really anxious to finish it, and we couldn't complete within the time that was allotted, within that 1-year time, so we had to get an extension. Our biggest challenge, although the ambition was one of the challenges, but the biggest one was the issues that refugees, that impact on refugee life here, that doesn't happen within Canada or within Ontario or whatever, issues that happen back home, people getting massacred, our people getting massacred, our people getting killed every day, and this bloody bodies swimming in blood, filling the social media, and everybody getting that kind of everyday experience. People couldn't eat, people couldn't sleep, people couldn't work. Recruiting has become very, very challenging. And it's not just the participants we were trying to reach, it's ourselves. We had not understood, we didn't realize that we were actually living the social determinants of health. And those determinants were not just local or systemic within the local context, but they were also very global. That has been paralyzing for us because we couldn't work. And there was tension in the research team, and we didn't know what it was, where it was coming from, because it was that re-traumatization that's happening today. The trauma we have run away from is happening all over again, and we couldn't understand why people couldn't get together, why we couldn't recruit, why we couldn't work without tension among us, because we were absorbing that violence and we couldn't relate to one another in a very smooth way, like as a research team. So I think you should speak to that more than I do, because they are the ones who have been trying to recruit, couldn't find anybody to recruit because people were grieving. There's this collective grief that was happening. So I would let them talk to that. Is that okay? Do you want to say?
I will just say that I really appreciate what you're saying, and thank you for sharing it, because there was once a research project I was leading with the Sri Lankan community. We started that project probably 2 months before the tsunami hit. And our research assistants were very affected. Obviously, the community was very affected. And actually, we had to halt the project for a period of sort of healing. And so I'm not sure how you're managing at this point, but if you do feel like you need maybe a period of, I don't know, sabbatical, like a period away from it, then maybe we should talk about something like that as one of the possibilities. Okay, was a comment here?
Hi. Oh, it's loud. Good afternoon. My name is Cathy Willis. We did, so I want to talk a bit about design, I think, is our issue. So thank you very much for your cooperation, Women's Exchange. We too got an extension. We did a piece of, a qualitative piece of research on women's experience of harm reduction within a violence against women shelters. So La Maison Rosewood Shelter in Midland has fully integrated harm reduction, and we do equipment exchange. We also allow women to consume alcohol if they wish inside the premises of the shelter. Nobody's turned away from any of our programs for active use. In fact, they're welcomed in. The design issue is that the research findings that have been unveiled, I would say, consistently match, current evidence within harm reduction. However, some issues that have been attributed to a harm reduction shelter are universal across all shelters, but we didn't have a comparative, right? And so our researchers are not familiar with the VAW context. So we're in continuing conversation, but certainly there are key findings within the research that are just, I think, are generalizable to all women's shelters in the province of Ontario, but most women's shelters haven't done independent research. So I think there was a design issue that we didn't realize. The other issue for us is having research that is embedded in the analysis of intersectional feminism and harm reduction, and I think that as we, of course we don't own the data, so as the data was coded, I think we started to see the emergence of a less robust analysis than we had hoped for. I mean, it's still a really good process, and it still is going to support the evidence that is continuing to grow. I think it could have been a little stronger, and I think that design issue also would have alleviated those attributions to harm reduction, which are universal. Thank you.
Well, thank you for that. That's a particular challenge that at this point in time, I don't know whether we can actually help you with. Yeah, certainly at the time of application, there is an opportunity for consultation about your research design and your methodology. So I am available to do that either through phone calls or emails, et cetera. In the 5 or so minutes that we have remaining, I'm wondering if we can talk about some of the unexpected positive outcomes of the research that you engaged in. Things that maybe were findings, or things that were secondary outcomes, or outcomes a year or two later. Anyone want to start that? Okay.
Hi there. I'm Mary Marr from the Northern Ontario School of Medicine, and we had the project working on intimate partner violence with First Nations. And I think we did a we did a photo voice project with women in 3 First Nations communities, and that was on the invitation of the First Nations. So there, the women's sort of approach though was right from the beginning. They didn't want to focus on intimate partner violence. They wanted to focus on healthy relationships. And we sort of conducted the photo voice project over about a couple of months or so, coming together on a weekly basis. And I think we had like a number of women actually sharing how empowering that was. So it wasn't just about the photo voice and learning how to, address intimate partner violence at the community level, but a lot of women felt that really the journey had been healing for them. So example was one woman, for example, and if you saw the video, she was on the video, she said her mother had gone to residential school, so she was never really hugged when her mom came home. And so she was saying that she couldn't give what she hadn't learned to give. And so as part of the project, her granddaughter would come to the weekly sessions, and she would say, okay, Grandma, why don't we just have a picture of you hugging Mom when she comes over to pick me up? And so the lady was talking about how hard that was for her. Like, so for hours, she had all these trepidations about not being able to do that. And then she said, when the daughter came, she just did it, and the granddaughter took the picture. And she sort of talked about how much that had sort of changed all of her relationships with her several daughters. And you said the next week she came over and she said, well, do you maybe want to stay and play some cards? And she said for the first time they played cards together, because usually the mom would just drop off the daughter and leave. So that was some of the things. And I think another thing that was amazing too is that the women really soon decided to wanting to share their story beyond First Nations. They said, we want to share this with mainstream communities in terms of reconciliation. And I think that was really powerful too. So the exhibit actually, now we're testing it with medical students and sort of interprofessional students, with high school students, as sort of an educational exhibit, because some of the stories, like people are telling us, sort of they are at the core, I think, of humanity, of what people are talking about. And so we are also working on having it developed as a continuing medical education, sort of accredited education material. So none of this was planned, but it was amazing that all this happened. Bravo.
My name is Leela Springer, and we're with the Olive Branch of Hope. And we did a project called Think Beyond Love Pink. It was a project that was geared towards women of African ancestry and how they deal with breast cancer. Not only that, the fact that breast cancer in women of African ancestry is more aggressive and it's often fatal. That there's a subtype called triple negative. I know that most women get that, but in women of African ancestry, they get it very young and they get it, and it's very aggressive. So that's what our project was about. So we didn't anticipate the problem of women not wanting to come. And we realized that they didn't come because of the level of silence around breast cancer within our community. So what we did, we hired somebody that was younger, since we were working with women 18 to 45. We got somebody younger that was heading up the project, and she was very aggressive. And she knew exactly what young people were interested in. So we had a Zumba class that we started off with. Everybody just loves that. And so our groups average about 30 to 35 for each one, I think, and which we thought was very good. So our challenge was trying to get the women to come out of their comfort level and actually talk about breast cancer and how it affects our community. The positive that came out of that, we had a group of students that were working with us from various universities, and especially those from the University of Toronto, the Scarborough campus, and they were so taken by the information that was shared. We were fortunate to work with Dr. Juliet Daniel that came with all her slides with all the scientific background that we didn't have. And when they began to explain how it relates to women of African ancestry, for those of us that came from the home country and we were spread all over the world, and we have to remember that our roots are back there, so whatever affects them affects us, and the fact that triple negative breast cancer is about 50% of the women in.
So about 50% of the women diagnosed with breast cancer in West Africa have triple negative breast cancer. And in North America, it's only 15%. So we think there's a genetic predisposition, so that's that's the angle I'm approaching it from. Yeah.
So the positive that came out of this, when the students learned all this information, they went back to the university and they started up a club so that they can raise awareness. And that meant a lot to us. We were feeling that we really achieved something. And they continue to work with us, and hopefully some other universities will catch on. And as we start the clubs and continue the conversation around breast cancer and women of African ancestry, then we know that eventually we'll get a movement going called Think Beyond Love Pink.
Hi, my name is Albert. I'm a medical illustrator, and we partner with a physician, Dr. Sill at Princess Margaret, and we made a video on trying to do patient education for a breast surgery two specific surgeries that are preventative to breast cancer. And through the process, since we are medical illustrators, we are mostly focused on the risks, the complications, the different challenges that are encountered in these procedures. But what we found, we did a very anonymous online survey to engage patients that either went through or didn't go through or are thinking of going through these procedures. There's a lot of personal info that they're willing to share with us, not sensitive things, but sorry, I am tripping over here. But it's the emotional content that we were getting from these surveys. And at some point, as medical illustrators, we thought that, are we sensitive enough to gauge this, to put this into the video, to address these concerns that the patient had? And we want to be really grateful to our partner organization, CBCF. They gave us a lot of good feedback on, how do you address this? How do you want to approach this kind of thing? So this is something that we as illustrators, especially because we deal with a lot of scientific facts and things that are more objective, that we found surprising. And we're very grateful to, learn during the process. So just want to share that.
So thank you. I think there are so many ways we get touched emotionally when we actually sort of do listen to each other, which was kind of the focus of the morning panels as well. We are just about out of time. In fact, we are out of time. Is there anyone who wants to make a last positive comment? Shirley?
I'm Shirley Brookstra, and 2 or 3 years ago, time goes so fast I forgot, I was directly involved with another women's exchange funding project on strangulation within an intimate partner violence. And from that, we got a lot of information from the women in terms of impact, prevalence of strangulation. And I think it was last year, Necka McGregor, the kind of CEO of Women at the Center, was at a conference with traumatic brain injury staff from U of T. And they started talking about, this is what's happening in traumatic brain injury women, and also kind of connecting that to what we found in strangulation. So the loss of oxygen to the brain and the impact. So I guess one really positive thing is if you start one thing with women at the exchange, you're obviously going to run into another one.
I think it speaks to ripple effects also. We really are all connected in some way or other. And from Women's Exchange, I want to thank you. And Paula, perhaps you want to say thank you?
Well, thank you to all of you for coming and sharing your challenges and the good things that have come out of your projects. And I think it's just amazing when you set off on a path, you often learn something, but then you learn things that are things you never really expected. And sometimes those are some of the most important findings. So it's been wonderful. I always love this part of our events when you hear the wonderful stories of things that have come from the adventures that we've all started on with these different research projects. So thank you all for coming and for sharing. And clearly you're welcome to stay and chat and network as much as you like, but it's a pleasure having you. Thank you very much.